This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology in training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Hi everyone, it's Jeff Ratliff, Deputy Editor of the podcast, here to introduce the Neurology Recall for February of 2024. For the Neurology Recall this month, we're actually going to feature updates and headache for both this month's recall for February, and we'll pick up where we leave off next month in March for our part 2 of this series. Listeners to the podcast will recall that in November of 2023, podcast contributor Tesha Monteith produced a fantastic series of podcast episodes on various updates in headache neurology. Bundling them all together for a single Neurology Recall would have been too much, and so we decided to spread out these episodes over this month as well as next month in March. For this February 2024 recall, we'll hear part 1 recapping the first half of that November 2023 headache series. The first episode you'll hear originally aired on November 2nd, 2023, and is a recap of the International Headache Society Conference, hosted by Tesha Monteith. In the next part, you'll hear Tesha's discussion with Stephanie Nahas on commonly missed and less known headache disorders that aired on the podcast feed on November 9th. For the final installment of part 1 of this 2-part recall series, we'll wrap up with Tesha's conversation with Drs. Deb Friedman and Kathleen Digre on IIH and low CSF pressure issues. We hope you'll agree that these are a fantastic series of educational conversations across multiple topics and headache, and find them as useful as we did here at the podcast. We hope you enjoy and come back in March for the next 3 installments in this series.
Hi, this is Tesha Monteith with the Neurology Podcast. Welcome to our 2023 November Headache Series. We're doing it again this year because it was such a success last year. I promise you, we have some exciting audio programming in store. We're bringing on the leading experts to discuss the most relevant and important headache highlights on a full range of conditions. You don't want to miss this.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology Podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
This is Tesha Monteith with the Neurology Podcast, back with our November series in headache. This session will focus on the most important highlights of the International Headache Congress, which just happened in September in Seoul, South Korea. It was the first time in Seoul and the second time the Congress was held in Asia since the 2005 meeting in Japan. The meeting was appropriately themed Rising Sun Over Headaches, towards a global access to headache science, technology, and healing, and was a great success. It was awesome to see so many people from all over the world, as well as great science. This could not be possible without the efforts of the Congress Scientific Program Committee co-chairs. With me to discuss is Gianluca Coppola from Sapienza University of Rome, Italy, Hayrunnisa Bolay from Gazi University in Turkey, and Casey Brennan from the University of Utah here in the US. I just want to start off with you telling us, what was the process like? You're at different time zones and you've selected some of the best science that I've seen.
For me personally, at least, this was just a really beautiful example of a global effort. We spanned, just the 3 of us, almost 2/3 of the time zones of the world. And then when we met as a full group, we really literally spanned the 24-hour day-night cycle. That was a cool experience in itself, but it also represented that this really was a global effort.
It was a global combination of minds almost every week for 2 years. It was, I think, a huge effort in order to combine our times, our work with the trying to put everything on setup as early as we can.
We were a good team and everybody was putting their, intellectual capacity. We were seeking for new opportunities to include mainly the all continents, all people, but it has to be with high scientific value. And we also spend a lot of time to invite particularly female researchers or young people in the field. So my time was always late nights or late afternoon time, but it was very difficult for Casey, like 6 a.m. or something, very early in the morning. And Gianluca was at the hospital, but that was good. Yeah.
So tell me a little bit about the submissions themselves.
Well, we had over 600 submissions total, and the science quality was uniformly incredibly high. I think because this is a global conference, we tend to get people's best work. Like Hayrunnisa mentioned, we also really made an effort to include work from every continent that met scientific standards and work from historically underrepresented groups in our field, right? Whether they be geographic groups, whether they be women in science, whether they be other underrepresented groups, there was a real effort to include this highest scientific standards and also really making this global.
I think we can say that we were proud to receive a lot of submission from young scientists who scored the highest when we have to score each abstract, So very proud to receive this huge amount of submission from young scientists.
So what scientific sessions did you find most interesting?
I really enjoyed the session on biomarkers and also the plenary session about morphofunctional activity of the migraine brain. They tried to explain us how electrophysiology and neuroimaging usually increase our knowledge about migraine pathophysiology.
Based on some of the science that was presented, what areas do you think are most promising in terms of advances in headache medicine, be it migraine or other headache disorders?
There are a huge improvement in the neuroimaging techniques, especially those analyzing some functional aspect of the brain. They can combine with electrophysiology as well as biological samples in order to improve and personalize headache medicine in general. And there are many new aspects about also cluster headache, how they can improve in the understanding of their pathophysiological aspects, especially chronic cluster headache. I will say the role played by the midbrain, for instance, or the dopamine and ventral tegmentum. So we improved in many aspects of the headache field.
I think all of us have an intuition, neurologists or headache specialists, that the cerebellum must be involved in migraine. It's the place where there's the highest burden of white matter lesions on MRI. Many migraineurs have sort of form-fruste cerebellar symptoms. They talk about being discoordinated, either episodically or chronically. And there's work from a new investigator in migraine, Levi Sowers at the VA in Iowa, basically showing us that there is an anatomical basis with rigorous scientific work for this cerebellar phenotype in migraine. What they did was stimulate, using primarily optogenetics, the median cerebellar nucleus. And just stimulating that one region with genetic specificity, they elicited migraine-like symptoms, photophobia, and others. So this is, to me, one of the exciting things about the conference is we have a lot of clinical intuition that's probably right, but that hasn't been validated. And instantiating this intuition in scientific models where we can build forward from them and generate new treatments, that's what's really cool to me.
We now are in the position that we can translate clinical symptoms in specific area involvement. So this is, I think, what we are dealing nowadays, and this is also for the future.
Hayrunnisa, what would you say was most promising to you? And then I want to ask all of you about what areas did we not see enough of?
There was also, I think, very important, maybe new concept. This is the gut-brain axis. And the irritable bowel syndrome, which is a functional gastrointestinal disorder. And it is related to the leaky gut, which is increased intestinal permeability and probably some destruction of the intestinal barrier function. And there was at least 2 studies showing that in the clinical one, the frequency of irritable bowel syndrome is increased in medication overuse headache. And that makes sense because in those group, we are dealing with the chronicity of the migraine and the food and, all this treatment is really difficult and challenging. And thinking about considering the, importance of leaky gut, I think that makes sense, or that may be important for their management on their treatment. And also, similarly, group showed in a female rodent model that non-steroidal anti-inflammatory drug use also cause lipopolysaccharide leak into the bloodstream. That was good addition to the clinical study, and they were also showing us that we need to focus more on the diets and food ingredients, and probably the stress and all the other factors which cause the leaky gut. That's also a new achievement, I guess.
And so what type of research would be nice to see more of?
We don't have a deep understanding of how migraine or any primary headache is developed. We don't really fully understand. And I would like to see trials or preclinical studies where they fed by clinicians and also the good scientists to solve as a whole this problem. Everybody is looking for a little part or very focused one part, but we don't have any holistic approach or holistic understanding. And that is one of the problems, that there is a huge gap translating preclinical studies to the bedside or in the headache field, unfortunately. And that brings us to another issue that I believe we need a new perspective to understand better, that everything is just repeating itself in the pathophysiology, in the treatments, but something, we need a paradigm change to go to this level, I guess.
I know Casey's excited about that because he talks a lot about paradigm changes. So go ahead, Casey.
I think there has in the past in our field been this rather, to use the words of now head of NINDS, primitive thinking about our disease state, right? This is a network disease. It's incredibly complex. It's individualized to the human that suffers from it because these are their brain networks that have grooved into some sort of dysfunctional pathway. And in the midst of this disease complexity, we've had these almost Manichaean debates about migraine is central, migraine is peripheral. It's a part of the central nervous system, part of the peripheral. Utterly specious debates, right? The disease involves an integrated nervous system that consists of central and peripheral parts. Another one of these Manichaean black and white debates is about migraine is neural, migraine is vascular. No, it's neurovascular. Right? The primary afferents that are likely the most important for this disease live on blood vessels. And so there are these sort of pendulum swings. And I think this was visible in the scientific content of our meeting. And I think there was good data to support this more integrative thinking that Hayrunnisa mentions about our disease. It really is sort of a dialectic, right? You get these sort of point, counterpoint, but we got a little stuck for a while with these debates. And I think we're moving past that. I do have some more hope. I can offer some specifics about data that says, the disease is neurovascular or that it's both central and peripheral if we want that.
Yeah, go ahead. My next question is about the overall state of migraine research, and you're just diving right into that last question. But go ahead and give us that specific data.
The most interesting integrative data for me, saying that in particular migraine is a neurovascular disorder, right? It's not neural, it's not vascular, it's both, is data from the group in Denmark showing that eNOS, not nNOS, so endothelial nitric oxide synthase, not neural nitric oxide synthase, was what was activated by one of the most potent activators of headache, levchromocalin, ATP-sensitive potassium channel opener. So the significance of this is that it is localizing release of a migraine-inducing substance to the vasculature rather than neural structures. And then Masuda Shina's group, also in Denmark, a separate group, when you use another category of potent inducer of migraine, ATP-sensitive potassium channel openers, and you use a version of these potassium channel openers that does not act on blood vessels, you do not induce migraine attacks. So there's a requirement for at least this class of drug to act on the vasculature to induce migraine attacks. There have been a lot of statements to the effect that the vascular phenotypes of migraine are bystander effects, are not part of the causal mechanism of the initiation of the migraine attack. The vascular phenotypes of migraine are an epiphenomenon and not mechanistically or causally involved in the generation of a migraine attack. This data is showing that a essentially non-vascular KATP opener does not induce migraine attacks is evidence against that. It's evidence that the vascular phenotypes of migraine likely are necessary in the generation of the migraine attack. But of course, again, we don't have to swing all the way that this disease is only vascular. Of course it's not. We require the nerves on these blood vessels to be activated to generate an attack.
Yeah, we just acknowledge the role of vascular structures, not we are swinging to the vasculature again.
Exactly. Like no more pendulum swinging. Let's,
Yeah.
Yeah, I was looking to the list of presentation of the Congress, and I must say that considering what Casey and Hayrunnisa have told us, we should move from considering migraine as a single pathology as a syndrome, I must say. You have a huge involvement of the immune system, of the inflammation, neuroinflammation, but also peripheral inflammation. Migraine is highly comorbid with many central and systemic disorders, cardiovascular, cerebrovascular, but also multiple sclerosis, epilepsy, gut disorders. So a lot of comorbidities and neurovascular involvement. Coming back to the initial evidence of the brainstem involvement in migraine, the spot in the neuroimaging, we know that brainstem monoaminergic system regulates the neurovascular coupling. So back to the basics. Why we have the involvement of the brainstem, which is the role of the trigeminal system, just the signaling of headache, of pain, probably not just pain. Why we have the involvement of the hypothalamus? Why just before the beginning of attack? Why not during the interictal phase, when probably something is going up to the tipping point of a migraine attack? We have such a huge amount of unanswered questions. Even in 2023 with monoclonal antibodies, for instance, why we have such an involvement of the peripheral system, neurovascular system, CGRP and PACAP, but we see patients not responding to monoclonal antibodies. Not to one, but even to 2 or 3 monoclonal antibodies, different monoclonal antibodies, not responding to Japans. So we have much more to learn in order to give an answer to our patients.
Well, I think that was a great way to wrap up this session. I really appreciate all of you being here because we got a lot out of this discussion, actually. It always surprises me how much when, great minds get together. So thank you so much. And be sure to check out the series going on this month. Hi, welcome back to our November Headache series. This is Tesha Monteith with the Neurology Podcast. Today, we're discussing a really important area in neurology, commonly missed and lesser known primary headache disorders. With me to discuss is Stephanie Nahas, Associate Professor of Neurology at Thomas Jefferson University. Thank you, Stephanie, for coming on to our podcast.
Thanks, Tesha. It's great to be here.
Well, I really wanted you on this podcast. You're such an excellent educator. But I know you also like these kind of zebra cases, and you've talked a lot about them. And so just kind of briefly, why are so many of these primary headache disorders frequently missed and result in diagnostic delay?
Mostly what's going to come to your clinical attention is going to be migraine, or it might be a secondary headache. And then folks just kind of tend to stop there. And everybody knows what tension type headache is like, and it doesn't usually require a doctor's attention. So people kind of get this laser focus of, oh my goodness, I have to make sure I rule out something scary. Okay, it's not something scary. I guess it's migraine. And so I think that's the kind of the dichotomy that a lot of folks fall into that trap. If it's not something scary, it's probably migraine. And you know what? They're right. It probably is, but it's not all migraine. And indeed, I even find myself falling into that migraine trap at times. So we have to remember that not everything is migraine, that there's a lot of overlap in headache presentations. This is one circumstance where a patient is very much allowed to have more than one headache diagnosis. And if you really delve deeply, oftentimes you can identify more than one just headache diagnosis. A classic example, I think, is occipital neuralgia. This is an entity that is both overdiagnosed and underdiagnosed. And what do I mean by that? Well, overdiagnosed, A clinician might hear some symptoms that are typical of occipital neuralgia presentation, and they stop right there. They say, you have occipital neuralgia. You have to go to the pain management specialist and get injections in your head or procedures on your nerve system, and that's the end of it. And they don't uncover the fact that this individual also has migraine, or maybe they actually have cervicogenic headache that's mimicking occipital neuralgia. Okay, so now on the flip side, we see somebody who clearly has migraine, probably chronic migraine, and they describe some symptoms that could be consistent with occipital neuralgia. And then we say, oh, yeah, that's just part of your migraine. Yeah, you just have some scalp allodynia. Yeah, you can get sharp shooting pains in migraine. It's all migraine. And we miss the opportunity to then address both entities with the best treatments for each and to achieve synergy in our therapy for our patients. So that's just one of many examples I could think of.
And then what about the trigeminal autonomic cephalgias? We have to talk about that because there's often a diagnostic delay with cluster headache, but then there are even more rare types of these, what we so-called TACs. So what are some ways that clinicians could better diagnose trigeminal autonomic cephalgias? Certainly talk about cluster headache, but then some of the other types.
Yeah, cluster headache is the key one, the critical one, the most common of all the trigeminal autonomic cephalalgias. This spectrum of disorders is relatively rare, but when you consider the fact that cluster headache is just as common as multiple sclerosis, why should it be getting missed all the time? I think there are a number of reasons. So number one, students, they all learn about cluster headache and they think it's really cool. There's like actual physical exam findings. There's something visible that happens to this person. It's really weird. It's really debilitating. And so they think that they can recognize it. They can certainly recognize it on a test, right? But they can't always recognize it when a patient sitting before them is telling them about their problem and that patient actually has cluster headache because the presentations are so heterogeneous. And again, there's often overlap with other syndromes, most notably migraine. We shouldn't always think, oh, if a man has headache, it's cluster. If a woman has headache, it's migraine. It certainly goes vice versa. And another reason that cluster headache goes undiagnosed for a long time is for most folks with cluster headache, they're only experiencing the disorder for a brief period of time. Weeks to maybe months out of the year, maybe only one bout every several years. And so they miss that opportunity to get to clinical attention, or they have a number of barriers to getting to clinical attention once their bout of cluster attacks begins. And then by the time they finally see somebody, it's over and they say, oh, well, I'm not going to bother going to the doctor. I'll just wait and see if this happens again, right? I'm sure you've seen this in your practice too, that you don't wind up seeing somebody until they've gotten so bad because they've progressed from an episodic state to a more chronic and refractory state. And here again, we've potentially missed that opportunity to intervene early and prevent the disease from progressing. Something that we've never been able to prove, obviously, but it's a tenet that we hold dear. Early intervention yields the best results.
So why don't you help us with some clinical pearls when distinguishing between the different types of trigeminal autonomic cephalgias, for example, attack duration?
These entities are typified by much briefer attacks than something like migraine or tension type headache. Cluster headache attacks are the longest of the attacks within this spectrum, but they're still not all that long. Of course, you talk to the person who's dealing with cluster headache and they'll tell you they last forever. But on average, an attack will last for about 45 minutes, anywhere from 15 minutes to 3 hours. And they're very dramatic. The pain is excruciating. It tends to be side-locked. There's this expression of autonomic outflow and dysregulation when you get the ipsilateral tearing and injection, ptosis, edema, rhinorrhea, oral fullness, and most of all, the agitation and restlessness that comes with these attacks. It's almost like a Jekyll and Hyde scenario. Somebody before an attack is like a normal person. And then when they get into an attack, the monster comes out and it expresses itself within that person until the attack finally ends. Another critical clue to cluster headache diagnosis is the predictability, the periodicity, the rhythmicity of them. So on a diurnal scale, the attacks tend to happen at specific times of day. On the annual scale, they tend to happen at specific times of year. And they happen multiple times per day for weeks to months on end, clustering together for a limited period of time. And then months and months and months go by before the next cycle or bout of these things occur. That's why we call it cluster headache. Now, of course, there's the flavor of cluster headache, chronic cluster, where there isn't so much a clustering of these attacks within defined bouts or cycles or spells. They just go on every day, day in and day out for a year plus without any break, or only a brief break of less than, say, 3 months. Now, contrast that with the next of these TACs that I want to tell you about. And by the way, TAC, trigeminal autonomic cephalalgia, that really describes the expression of all of these. Paroxysmal hemicrania bears the most similarity to cluster headache. The key differences are, number one, the attacks are not quite as long. Number two, there isn't that predictability in that circadian rhythm or the circannual rhythm. They tend to be much more random, but a key trigger for paroxysmal hemicrania attacks can be head turning, whereas a key trigger for cluster attacks can be alcohol consumption. Now, triggers are a whole other Pandora's box, and we could do a whole other topic just on triggers. But this is another thing to ask about when you're faced with somebody who's dealing with headaches and you're trying to diagnose what they've got. Paroxysmal hemicrania, unlike cluster, these attacks, they don't tend to happen for restricted periods of time and then go into long remission periods. Most patients most people who have paroxysmal hemicrania, they'll have it day in and day out, or at least every other day. And they'll tend to have a greater number of attacks per day, although they're less in duration and less in intensity. But they tend to have all the same associated features with the autonomic dysregulation. Moving on down the spectrum of the TACs are the Nahas syndromes, the short-lasting unilateral neuralgiform headache attack syndromes, which currently we describe in two flavors. SUNA, meaning just with autonomic features of some sort. You just need to pick one out of a list of a number of autonomic features. And SUNCT, in which the individual must have two specific autonomic features. The C stands for conjunctival injection, and the T stands for tearing. So with SUNA, you have one or neither one of those, but you have to have at least one autonomic feature, and that could include something like ptosis, for example. Now, the last of the TACs is a little bit of an oddball, and it made it into the formal classification within this spectrum only in the most recent iteration of the ICHD, and that is hemicrania continua. What's different about hemicrania continua? Well, unlike all the other TACs in the spectrum, these aren't necessarily discrete spells. As the name implies, half the head hurts all the time. What is discrete are the superimposed attacks of unilateral head pain with, again, an array of autonomic features. And these superimposed attacks tend to be very brief, although they could be somewhat longer. It's not really clearly defined how long those superimposed attacks ought to be to make the diagnosis, but a couple of things are clear. Number one, has to be side-locked. Number two, has to be continuous. And number three, there has to be these superimposed attacks with autonomic dysregulation as part of the phenotype. And finally, like paroxysmal hemicrania, absolute responsiveness to therapeutic doses of one of my favorite medications in the entire universe, indomethacin.
And you've been very consistent with indomethacin being one of your favorite medications in the universe. I think you've been saying that for at least 10 years. I'm glad that it's your favorite. Speaking of indomethacin, some issues with the TACs, especially the indomethacin responsive ones, are that patients may not get the proper indomethacin test. So why don't you clarify what an appropriate indomethacin test is and remind us about the potential side effects or adverse events associated with indomethacin.
Indomethacin, it's an anti-inflammatory medication of the nonsteroidal variety. So, of course, any concern or caution that goes along with any NSAID also goes for indomethacin, namely the potential for bleeding, ulcers, renal damage, etc., even hepatotoxicity. So that's kind of across the board for NSAIDs. Now, as far as NSAIDs go, indomethacin does tend to be a little harsher on the GI tract in my experience with my patients. Very rarely with any anti-inflammatory drug, there can also be some central effects causing drowsiness or mood changes or, kind of mercurial, strange kind of brain stuff. So I do caution my patients about that as well, particularly with indomethacin, because I've seen it more than a few times. And It's really peculiar. I can't quite explain it. So that's kind of ground rules for safety with indomethacin. Then what is a good, fair try of it? I would recommend starting with a 25 milligram capsule, one at a time, 2 or 3 times a day with some food to begin with, because that might be enough. I have found that for some of my patients that are really exquisitely and dramatically responsive to indomethacin, between 25 and 75 milligrams per day is all they need. Now, if you're faced with somebody who you believe with 99.9% certainty that they have an indomethacin responsive syndrome and they haven't gotten better within the first few days of 75 milligrams, then you counsel them to increase the dose cautiously, but fairly aggressively. Just wait a few days in between each dose increase. And again, watch out for adverse events. By the time you hit 50 milligrams 3 times a day for a solid 2 weeks, if nothing has happened, nothing is likely to. Almost everybody responds by that point in time. However, there are a few individuals who will be stragglers and who will take a little longer. And some clues that you might be onto something are that they're getting a little bit of relief so far. So as long as they're tolerating it, I have them keep pushing it up to a maximum of 100 milligrams 3 times a day and let it settle for a couple of weeks. If after that point in time they aren't dramatically better or they're not tolerating it, I put it aside and we start exploring other treatment options. And I come back to the history because maybe the diagnosis was not correct. There are a number of cases of phenotype that suggest indomethacin responsiveness. But if you're missing a critical key element of a secondary contributor or cause and you're not addressing that, all the indomethacin in the world may not be enough for that patient.
Why don't we move on to some of the epicranial headaches described as pain over the scalp?
These are also some of my favorite because, again, I think they're much more common than we realize. We might be seeing a patient, their main concern is that they have debilitating migraine. But if you ask them and if you probe them, you'll find that they also have these other little headaches on top. And compared to migraine, they're like no big deal. So they don't really tell you about them. Or they think, oh, maybe this is just some weird kind of sensory thing with my scalp. Or maybe even they just believe, oh, it's part of migraine and I don't even need to talk to my doctor about it. But I think you'll see it a lot more often if you just start asking, do you get any stabbing pains in the scalp anywhere? That's stabbing headache. Sometimes our names are, pretty straightforward and they really describe the entity that we're dealing with. Nummular headache, that term comes from the ancient Greek word for coin. And that's because the headache itself is like in the shape and size of a coin somewhere on the scalp. And it tends to just be there and only there without any radiation, without any change, without any other associated features. And you might find it in isolation. But I've often found that patients may have a nummular spot of headache on top of their other existing primary headache disorder. Now, you also mentioned epicrania fugax, and this is a really weird one. Zigzag headache is another nickname that's been given to this because that's really what it's like. Imagine lightning bolts of zigzags sort of traversing across the surface of the scalp in a painful, sharp, or even burning or prickling sensation. These are very brief, but they can be very, very intense and very, very debilitating. Again, I rarely see these in isolation, but sometimes I do. When they're bad enough, a person will be motivated to come see a specialist about it. But much more often, I will see this in combination with something like chronic migraine.
So how common is nummular headache? And can you describe a case that highlights successful treatment?
Nummular headache is not all that common, but I think it's more common than we realize. Again, I think we don't ask about it quite as often. Technically, it should be an isolated entity, pain in one fixed spot on the head without any other secondary cause identified, like a skin infection or some sort of growth or what have you, and featureless. We don't really know what causes it. There are a lot of theories. The treatment can be very frustrating because we don't really have a lot of good directed treatments towards it. But a case that's very high in my mind, this is a patient that I actually started seeing when I was a fellow, and I still see him. He came with a story of One day, it happened to be Thanksgiving. They were sitting down to dinner, and all of a sudden, he had a spot of pain that appeared in his left temple. It just turned on, and it was really pretty bothersome, and it never left him. So he came to tell me about this pain in the side of his head, and that's what bothered him the most. So I thought maybe this is nummular headache. I did ask him some more questions. It turns out he did have some migrainous quality some of the time when the pain would become very intense. He would become a little sensitive to light or noise or a little nauseated. But mostly it was just this pain right there in the left side of his head. And it switched on one day. He remembered clearly the date that it was. So here we have a guy who's got new daily persistent headache of a nummular phenotype with some migraine characteristics. All right, what am I going to do? We hear a lot of scary stuff here, right? Because new daily persistent headache really scares us when we hear that. It can be notoriously difficult to manage unless you take a systematic approach, and we could talk more about that later. But we also have nummular headache, this weird entity that we really just don't know how to treat it with. Plus, we've got some migraine mixed in. All right, so where do we begin? Where do I start? Well, being a specialist at a headache center, and mostly what we see is migraine, I'm most confident pulling out my migraine toolbox. So that's what we start exploring. Anything and everything that you use for migraine. And his case was really, really tough. We had to even go up to infusion treatments and even a hospitalization to try to get on top of this. And everything was working kind of, sort of, a little bit, giving him temporary results, but still nothing was completely eliminating this pain. We even tried local anesthetic injections right into the spot, which strangely didn't even make the spot numb. He could get numb other places, but not there. Really weird. Still can't explain that one. We even tried a little bit of a neurotoxin injection right into that spot, and it still didn't work. Years go by, and there's a neurotoxin that becomes approved for chronic migraine. So we decide to give it a try because he's still got some of that migraine flavor. So we do the neurotoxin injections, not just in that spot of where the pain is, but spread widely over the scalp of the forehead, the occiput, the cervical paraspinal muscles, and the trapezius muscles, the traditional injection pattern. And guess what? It worked. And the more we did it, the better he got. And in between his treatments, he was essentially pain-free. At this point, he's pushing 70 years old, and I think he's kind of outgrown the headache at this point, which sometimes happens because we stopped the neurotoxin treatments a long time ago, and we've been slowly weaning off some of his other medications. And now he just checks in once a year to make sure that nothing new has come to light and that if things get out of hand again, he's still plugged in with us and can get our expert advice. That's a great illustrative case of a blend of different syndromes, not only new daily persistent headache and chronic migraine, but also this nummular phenotype. And a guy, too, right? So it's unusual that middle-aged guys come to see us. So this is a true zebra, like you say.
Yeah, well, I think it's interesting, and it tells us how much more work we need because we are really just have phenotype to go by most of the time. You did mention new daily persistent headache, and so I think now is a good time to talk about what that is and how do we treat it. These patients are often having a lot of suffering.
As the name implies, new daily persistent headache begins anew on a particular day and persists without remission. By definition, the date of the onset should be clearly remembered, and the headache should have become daily within 3 days. I've never seen a case where the headache started on Monday, was gone on Tuesday, came back on Wednesday, and then stayed for all eternity. Just about every case I've seen, it's been right from the get-go, constant daily pain. Now, I don't always encounter folks who clearly remember the day that it started, the exact date. They can say that it was like a switch flipped or they woke up that way. But for whatever reason, the exact date is not so clearly remembered, unless, say, it was linked to a special event or a holiday. For example, I've seen cases of new daily persistent headache that started on Thanksgiving or on Christmas or on Valentine's Day, or the day waking up from a surgical procedure, or the day arriving in a new country for a vacation after air travel across many time zones, or the day after a vaccine of some sort, any vaccine, and these links to how it started is so critical in formulating your treatment plan. Your plan of attack, your management really revolves around that careful and detailed history to try to uncover, all right, maybe I can figure out what started this. We know when it started, but can we figure out what started it? For example, if it was associated with a vaccine, okay, maybe we're thinking about some sort of systemic inflammatory type of a problem. If it started after a surgery, okay, maybe we're thinking of perhaps a low-level injury or strain to the neck from the intubation procedure, or somehow in the way the patient was positioned during the surgery, just some examples. So that kind of helps get you towards what may have turned it on. And even if that switch has been removed, the headache is still going. So now we have to figure out some alternative switch to switch it back off. Then in your history, you're also trying to uncover the key and critical aspects to the phenotype. Because when we don't have a secondary cause to go after, or when the secondary cause has been addressed and remediated, but we're still left with these symptoms, well, we treat to the phenotype. And so if it seems to behave like migraine, we pull out our migraine toolbox. If it seems more like a tension type headache or a cervicogenic headache, those are our targets for our treatment. And then we proceed from there in our usual trial and error fashion. But again, never giving up on this diagnosis and never being afraid to revisit the history and wonder to yourself, am I missing something? I'll tell you another quick case of new daily persistent headache that I like to highlight in some of my lectures on this topic. We saw a patient a number of years ago with a clear new daily persistent headache presentation, had migraine phenotype, not responding to migraine treatments, reportedly normal MRI of the brain, which we never saw until a couple of years later. And indeed, it didn't look that bad, but something about it just looked a little off. So we repeated it, and what seemed to be a little off on the repeat scan was clearly a little off. This patient had very thick skull and descent of the cerebellar tonsils with a crowded hindbrain. And what was really happening is that this woman was developing hyperostosis, and her brain was slowly being squeezed out of her skull, down through the foramen magnum and into the cervical spine. And so no wonder medications weren't working. She was, literally like toothpaste. Her brain was starting to be squeezed out of her skull. And the definitive treatment was actually a suboccipital decompression procedure that relieved all the pressure. Everything rose up. Her tonsils were no longer peg-like and descended down into the cervical spine. There was plenty of room in there, and her headaches got better, and she didn't need medication anymore.
That's a really good point, and reminder to always think about secondary causes. Oftentimes, patients have had many MRIs, but you have to take a look at that as well, right?
Yes, indeed.
Let's move on to hypnic headache. It's also a rare disorder and a very interesting one. Anything new about hypnic headache? And just remind us what hypnic headache is.
Hypnic headache, again, where the name is somewhat descriptive. Now you think hypnic and you think hypnosis. Oh, okay. So is this a headache that comes after you've been hypnotized? Is this a headache that makes you feel like you're hypnotized? No. The hypnic part of it implies that it tends to happen during sleep, fairly exclusively. And in fact, it's given the nickname of alarm clock headache because what a patient will describe to you is that in the middle of the night, they're just suddenly awakened as if an alarm clock went off, but it's not an alarm clock with sound. It's an alarm clock with pain, head pain, pretty bad head pain, typically described as moderate, if not severe, often holocranial and throbbing. But apart from that, not much in the way of a migraine phenotype. The headache tends to go away on its own after the individual is awake for a little bit. So they may have to get up and out of bed and walk around, and then eventually, okay, now this headache is just magically gone in a matter of minutes. If not, they may treat it with analgesics, and then it usually goes away, and then they can go back to sleep. But imagine having this happen night after night after night after night. And that's what hypnic headache is like. Now, for the lucky individuals with hypnic headache, it only happens 10 to 15 nights out of the month. It has to happen at least 10 nights out of the month for the diagnosis to be ascribed. But again, you need to identify or rule out, I should say, that there is a secondary cause. There was a good review that was just published this year in Cephalalgia, and I'd encourage anybody interested in hypnic headache to go ahead and read it, because not only does it go over the description and the epidemiology and the variety of presentations, it really delves into some of these more oddball cases. describing secondary causes, which can include brain tumors, vascular abnormalities, systemic problems such as nocturnal hypertension or fluctuations in blood glucose. And in addition, we're identifying that hypnic headache doesn't just affect older individuals. It can occur at any age. And in fact, there are case series which have been reported of children with hypnic headache. So it's pretty rare, but it's a real fascinating entity that we still don't quite understand why it happens. But because it's linked to sleep, we think that there's got to be something rooted in the hypothalamus.
And why don't you share with us the best treatment strategies for hypnic headache?
This might surprise you, but taking a little caffeine before bedtime can cure hypnic headache. It doesn't make any sense to me. And in fact, why should taking caffeine before bed, something that we tell our patients never, ever to do, why would that work? And why would that give them a restful night's sleep? I really don't know. But somebody with true hypnic headache can have caffeine before bed. It won't keep them awake, and they will sleep through the night because they won't get an attack. Now, if a patient doesn't respond, if their hypnic headache, I should say, doesn't respond to caffeine or they can't tolerate it, then there are, thankfully, a few other options. And here's another one that you might not always think about pulling out of your headache toolbox: lithium. Lithium carbonate is considered among the first-line treatments for hypnic headache and for cluster headache, by the way. So here's another reason why we think there's got to be some link to the hypothalamus and why lithium works. Again, who knows? We have not unlocked that mystery, but lithium can work for this. Indomethacin, here's another role for indomethacin potentially. Of course, knowing that hypnic headache most commonly affects older individuals, you got to be very careful with any anti-inflammatory drug in somebody who's in that older age set. Melatonin is also purported as a pretty benign, but often quite effective treatment option.
Great. I think that's really fascinating. We often think about older patients, but it's really important to keep an open mind to really get this diagnosis. So I want to move on to exertional headaches. There are a number of etiologies that can produce exertional headache. How do you approach patients with these differing presentations, whether it's related to cough, sex, or exercise?
This can be another frustrating and challenging spectrum of entities to treat, but that doesn't make me shy away from it. And I hope it doesn't make anybody else shy away from it, because you can be quite successful. And sometimes you can be the hero in these presentations. You do have to exclude a dangerous secondary cause. And primarily, we're worried about pathology in the posterior fossa or a vascular etiology. So I image all of these folks with a brain MRI, and I also look at the vasculature, including the veins. So a full look at the arteries and the veins, just to make sure that we don't have any funny business going on there. And then if I'm confident that structurally everything is looking good in the brain and the upper cervical spine, then we go on to treatment. And my number one is, guess what? Indomethacin. Here's another opportunity to use indomethacin, either daily or preemptively. It depends on how often the exertional headache occurs. So now if you've got an athlete who's got to train and they have to be taking indomethacin a lot, and they may be actually playing a contact sport, well, you may be a little hesitant to put your patient at risk for bleeding from trauma. So what are some other things you can do? Well, propranolol actually is reported to be quite helpful for these exertional headaches. If the exertional headache is also associated with increased intracranial pressure, then you have to address the increased intracranial pressure. So if structurally everything looks good and you've treated, but you're not getting the results that you're looking for, even in the absence of papilledema or other symptoms suggestive of increased intracranial pressure, look for that. The final thing I will tell you to look for, and I have not encountered a case like this, but I know colleagues who have. If you've got somebody who's a little older and may have some vascular risk factors, and they are telling you they have exertional headache, the alarm bells better go up for cardiac cephalalgia in those instances. Because instead of the cardiac ischemia manifesting in the typical way with chest pain, shortness of breath, nausea, diaphoresis, etc., with pain radiating down the left arm or up to the jaw, these folks, their only symptom may be a headache, and maybe with a little nausea, maybe with a little sweating, but hey, that's expected. They're exerting themselves, right? So you have to really be on the lookout for those cases, because If you send them straight to cardiology, get the stress test, get the cath, do the whole cardiac workup, and you find that they've got an occlusion in a major vessel, and then you get them treated and their headache goes away, not only have you helped them eliminate their headaches, but you've potentially saved their life.
Thank you for sharing that story. It's so important that we spread the word about cardiac cephalalgia. So thank you so much for summarizing this. I think this was great and very helpful in shedding light on these lesser known primary headache disorders.
My pleasure. Thank you for giving me a platform to ramble on and on about a topic that I hold near and dear to my heart.
Like indomethacin. Well, that about wraps it up. Hopefully this discussion will help improve your awareness on some of the most commonly missed and lesser known primary headache disorders. This is Tesha Monteith. Thank you for listening to the Neurology Podcast. Hi, this is Tesha Monteith with the Neurology Podcast. I'm back with the November headache series. This session is focused on both high and low CSF pressure disorders. With me to discuss is Kathleen Digre, Professor of Neurology and Ophthalmology at the University of Utah, as well as Deborah Friedman, a neurologist in Dallas, Texas. Both Kathleen and Deborah have been instrumental in helping us better understand the diagnosis and management of both SIH and IIH. Thank you, ladies, for coming on to the podcast.
Well, I'm delighted to be asked. And of course, I couldn't be happier than to be with my colleague and friend, Deborah Friedman.
She took the words right out of my mouth.
That's what I mean. You're the dynamic duo of CSF pressure disorders. What's new in the diagnosis of idiopathic intracranial hypertension?
Well, I'll be happy to start out giving you what's not new, just because I think we need to make sure that we all do a history looking for risk factors for raised intracranial pressure. Sometimes medications can cause it, like tetracycline, minocycline. Sometimes sleep apnea, obesity, and its comorbidities are very rampant. And for every patient, we have to get an MR with gadolinium. And in some cases, if it's atypical, we have to get a venogram, a MR venogram. We have to do a lumbar puncture to rule out a secondary cause, even though some of our colleagues are thinking we don't have to do that, but we really do. And we have to get visual fields. And for neurologists, this is really a challenge because most neurologists don't have visual field in their office. And sometimes it's nice to get a optical coherence tomogram on some of these patients too. So that's not what's new, but there's a lot of things that are new in some of the treatments for weight loss, which I know we're going to be getting into, and some of the treatments for reducing the intracranial pressure, like stenting, is another new thing.
Deborah, I want to ask you about IIH without papilledema, because I know you've been involved in some of that writing.
You know, on your podcast, you have two of the three people who wrote the diagnostic criteria for IIH that were published in Neurology in 2013. And those criteria, according to us anyway, still stand. We talked about whether we should revise them again because it's been 10 years. But really, as Kathleen notes, that not that much has changed. So when the two of us and then Grant Liu, who was the third co-author, when we wrote the criteria, we purposely tried to make it difficult for people to make the diagnosis of IIH without papilledema because we thought that it was being overdiagnosed, particularly amongst headache specialists. Kathleen and her team at the University of Utah did a study where they looked at their neuro-ophthalmology practice and found that only 5% of their IIH patients did not have papilledema. And a lot of those patients had non-organic functional visual loss. A lot of them just had intractable headaches. So we stand by our diagnostic criteria. And in order to make a diagnosis of IIH without papilledema, there are two ways to do it. Either you can make a definite diagnosis if you meet all the other criteria, meaning the MRI, the lumbar puncture opening pressure, the normal CSF pressure. If the patient also has either a unilateral or bilateral 6 nerve palsy. But in practice, that really doesn't happen very often because most people get papilledema before they get a cranial nerve palsy. So you can make a suggested diagnosis, but not a definite diagnosis. if the patient meets criteria based on imaging findings. So there are 4 cardinal imaging findings, and they need 3 of them, and those are empty-cella or pituitary flattening, expansion of the perioptic subarachnoid space, flattening of the posterior globe, or transverse sinus stenosis. And transverse sinus stenosis actually turns out to be a pretty good predictor, but you have to keep in mind that this is a diagnosis that is a package deal. Like one sign in particular is not going to make the diagnosis. And an MRI that shows some abnormal findings in the absence of anything else does not make the diagnosis. So I would be really wary and leery of making a diagnosis of IIH without papilledema. I just don't think it's all that common, and I still think it's being overdiagnosed.
And I would agree.
I think part of that is we get MRIs very often. And I know that I've at least had some cases of patients with intractable headache, migraine. They get a lumbar puncture and it's marginally elevated or normal, but they have a couple of those findings. And what do we do with those cases?
Well, the group at Emory has done a lot of investigation into this. And their bottom line is send the person to an ophthalmologist. Like, we're getting all these consults for people who are being referred because they have an abnormal MRI of the brain, and maybe somebody reads out transverse venous sinus stenosis when it's really an atretic venous sinus that they were born with. And so again, you have to follow all of the diagnostic criteria, or you run the risk of diagnosing the patient with something they didn't have. And the problem is then they undergo all these procedures, and sometimes surgical procedures or interventional procedures that they didn't ever need to have. And those procedures are not without potential risk.
So let's talk about some of those procedures and at least potential risk factors that might lead to negative outcomes that would warrant a procedure.
I think it's been very clear that when people present with severe papilledema and visual field loss, we sometimes call this fulminant idiopathic intracranial hypertension. These are people at very high risk. And this is really an emergency where you have to make the diagnosis quickly. We have established a program where we put them in a lumbar drain situation and get the pressure off. And then we make a decision about what kind of surgical procedure we need to do while we treat them with high doses of acetazolamide, hoping that that will control it. And there are many other studies out there that have said besides severe papilledema and fulminant idiopathic intracranial hypertension, male patients, maybe because they come in late, African American, are more likely to have severe visual loss. If people have visual field loss at the onset, that's another group of high-risk individuals. The other group that I find really difficult to take care of are people who are unreliable for follow-up. So let's say you make the diagnosis, you get a field, you know what they've got, you put them on acetazolamide, and they don't come for follow-up. So those people are another group that I really worry about as well. Deborah, what do you think? Do you think there are other people that we should be worried about?
I would also add people that present with visual acuity loss at presentation. And a lot of neurologists no longer feel all that comfortable doing a fundus exam, and you can't do an automated visual field at the bedside, but you certainly can take somebody's visual acuity, right, using a near card. So people who come in that already have loss of central vision at the time of their presentation have a much higher risk of experiencing long-term visual loss.
So you spoke about papilledema and some of the progressive findings. What about ultrasound? Is there a role for ultrasound in predicting those that might have a more negative course?
In my practice, no. I love ultrasound for lots of reasons, like looking for buried drusen, that somebody might have buried drusen. You can have buried drusen and swelling, and that might be another risk factor for visual loss. And a lot of people do what's called the 30-degree test to see if they think the pressure is elevated, but I haven't really used ultrasound as a predictive thing for visual loss.
So let's move on and talk about weight loss. I mean, when I was training, I was kind of like, weight loss is the gold standard. I know it's far more complicated than that. And there's a heterogeneous disorder. We have to preserve vision and all those things. But in many of our patients, we do have to talk about weight loss. And I think neurologists don't always do a great job of educating, and not just neurologists, but maybe clinicians in general. We don't get a lot of training in medical school about nutrition and how to lose weight. So let's talk about some of these newer drugs that are on the market. Everyone's talking about glucagon-like peptide receptor agonists. What are your thoughts on that?
So I've been looking into this because I've got a lot of patients that are coming to me wanting to be on this drug. And then what do we know about these drugs for idiopathic intracranial hypertension? Well, first, these drugs have been used for diabetes for several years and have been very good at helping people lose weight when they've got adult onset diabetes and for diabetes prevention and weight loss. There are only 2 trials that I'm aware of looking at the GLP-1 receptor agonists. The one was done by the Birmingham group. Mitchell was the primary author. Alex Sinclair, I think, was a senior author, published in Brain of 2023. And this was a very good trial where they enrolled 16 patients and they randomized 15 of them either to exenatide or placebo. It was a prospective trial, and they all had very in-depth telemetric monitoring of their intracranial pressure at 2.5 hours, 24 hours, and 12 weeks. And the exenatide did lower the pressure at each of those time points. What was interesting to me, however, was the number of days improved, but the severity did not improve. So we need a lot more information on this drug in that prospective trial. Then another report came out in the Journal of Headache Pain, where they took 39 patients with IIH and treated 13 with a receptor agonist and 26 to the usual care. And they achieved 12% weight loss with those in a GLP-1 group versus 2.8% in the placebo group. But the visual outcome at 6 months, no difference. Headache improved in the GLP-1 group, 76% improved versus 40% on placebo. And there were some adverse events, mainly nausea and some gastroparesis. I think this is a story to be continued, because it is a remarkable drug for weight loss, but it does have serious side effects. Some of the big reviews that have looked at the very serious side effects, things like pancreatitis, gastric stasis, and a lot of nausea. So I think the jury's not out on this, but we're going to see more of it. The biggest problem I've got in my patients is that they get prescribed this and then they can't get it because it's not available. It's just, there's a shortage of the drug.
So, Deborah, have you sent patients for bariatric surgery? How often have you done that? And what does the literature say?
I have sent some patients for bariatric surgery. The number is not huge. And sometimes it gets approved and sometimes it doesn't get approved. Unfortunately, a lot of times the third-party payer has more to say about what the patient needs than we do. But there was also a trial that the Birmingham group did called the IIH Weight Trial, where they randomized people to either receive bariatric surgery or just kind of standard of care dietary measures. Not surprisingly, the people who got bariatric surgery lost a lot more weight, right? That was their primary outcome, was weight loss. And I don't think any of us were too surprised to see that they lost weight. The outcomes that I would say, as neuro-ophthalmologists anyway, that we are concerned with, such as their visual parameters, they were all secondary outcomes. Headache was a secondary outcome, but in general, people seem to get better. There are studies from the older literature on bariatric surgery looking at people who had migraine, showing that weight loss even helps migraine. So I'm not sure that the improvement in headache is entirely due to lowering intracranial pressure in these people, although the ultimate result was that it did lower intracranial pressure, but it may have a totally different mechanism that I'm not really sure about.
Kathleen, what are your thoughts on that?
I would like to just add there is a systematic review that is in a preprint format in the journal Neurology that is going to be coming out, where they really did a wonderful systematic review looking at 17 studies of bariatric surgery, several studies of lifestyle interventions and diet interventions, and they really clearly showed that bariatric surgery does give you the most weight loss, and it does give you probably the most decrease in intracranial pressure, although it was pretty close with if people can really lose the weight. In the cases like the IIHTT, where they did a lumbar puncture after the weight loss intervention, they could show that the pressure did come down. And they even did look at headaches. So I would urge our listeners to look at the Green Journal when this study comes out. And it's a very interesting study, and it really kind of makes an argument for weight loss surgery, especially gastric bypass versus some of the other less invasive surgeries. But it's one of these things where we can make these recommendations for some of our patients that really can't lose the weight. But then again, sometimes the insurance companies won't approve it. I've had so many cases where I've tried to get that approved. I've given them articles, I've written letters, and you just can't get it done.
I would add that a lot of these people have been struggling with their weight all their life. And just telling somebody to go lose weight, it's not easy. They've tried a lot of different ways to try to lose weight and have been unsuccessful. So to have options like, the new medications that we have, the GLP-1 receptor agonists and bariatric surgery, I think would be a real benefit to many of these people who are kind of at their wits' end, and they've tried everything they know how to do. And a lot of these patients also have polycystic ovary syndrome, which makes it even harder to lose weight. So I think, a little compassion is probably due there as well.
And also, Kathleen, you were speaking about some of the surgical interventions like venous sinus stenting. Why don't you talk a little bit about that, any recent clinical trials, and where we are as a field in being a little bit more accepting of these procedures?
We use surgical procedures for visual loss, not for headache, not for anything else, but we got to do them for visual loss. We can't be just doing procedures on people. And the procedures we have for visual loss with IIH, we have optic nerve sheath fenestration, which does help with the papilledema, sometimes doesn't help with the headache. We have shunting, which sometimes gets the pressure off and may help for a while, but these shunts tend to fail. So one of the new kids on the block that's been around for a few years and has been looked at is called venous sinus stenting. Now, this procedure is an invasive procedure, and you have to put a stent inside of a vein to try to get past a stenotic area or maybe an arachnoid granulation that's causing a stenotic area. And they do really drop the pressure. And there are lots of small studies. There's some bigger studies. There's a wonderful systematic review that was published in the Journal of Neuro-Ophthalmology by one of our colleagues, Dr. Dinkin from New York. And so pressure definitely comes down with the stents, and symptoms get better, pulsatile tinnitus gets better, and the papilledema does get better, and headaches do improve, but that was the least thing that improved. In fact, some of the people get really bad headaches at the time of stenting, because remember that the trigeminal system innervates these veins, and so they can get pretty bad headaches. And there are complications. The stents can thrombose. You can get a subdural hematoma. You can get cerebral edema. The stent can migrate, and there's even been death. So I think it really has to be a well-chosen person. I personally have done it on very few people, usually with very fixed stenoses where I've tried other things and it hasn't worked. And I can't get the papilledema down due to the other procedures. I've sometimes resorted to the stenting. I think we have to be really careful about this procedure.
Deborah, what's your experience?
Well, Dr. Jenkins' paper, he also points out that 9% of people had recurrence down the line, and they had to go have a surgical procedure. So, it's not perfect, but it, in general, I think is a good option for many people. The metric that seems to predict improvement the best is the magnitude of the gradient across the stenosis. So when the interventional radiologist is trying to decide whether or not this person is a good candidate, they do manometry and they measure the venous pressure on one side of the stenosis, and then they measure the venous pressure on the distal end of the stenosis, and the difference between the two is called the gradient. And the higher the gradient, the more likely it is the patient will have a good result. And the magic number is around 20, although they will stent for numbers that are much less than that. A lot of places, their cutoff is about 8 millimeters of mercury. The higher the gradient is, the more likely it is the patient will benefit.
Okay, so we have a patient diagnosed with IIH, had the appropriate testing, and lost weight, listened to the podcast, decided to lose some weight, got put on some diuretics. Vision has improved, papilledema is resolved, but I'm still having this darn daily headache. Dr. Friedman, Dr. Digre, yeah, sure, my vision is better, yeah, but I'm with this headache and I can't function. Fix me.
Well, this happens in about 2/3 of people who have IIH. They have continuous headaches, probably as a result of central sensitization from the time that their intracranial pressure was elevated. And what we know is that acetazolamide is not a great headache drug. It's just as good treating headaches as placebo, which is what we found in the IIH treatment trial. And yes, people's headaches got better, but no better with acetazolamide than placebo. The basic strategy is to treat their headache, and we treat it by their phenotype. And in the IIH treatment trial, the most common phenotypes were either migraine or probable migraine, or less commonly, tension-type headache or probable tension-type headache. So we would treat them like they sound. I like to use topiramate in patients who have IIH. You get the benefit of reduction of CSF pressure, as well as maybe some weight loss, as well as headache improvement, or you could use zonisamide for patients that don't tolerate it. There was actually a really cool study that was just published. It was done in rats, so I won't belabor the point. But basically what they found in rats was that the combination of acetazolamide and topiramate worked better than either one of those alone. So there at least is some scientific rationale for combining them. They work by different mechanisms because topiramate had an effect on some of the genes expressed by the choroid plexus, whereas acetazolamide didn't. So you could try combination therapy. But other than that, the field is wide open. We can use whatever we would normally use for anybody else who has an intractable headache, including botulinum toxin A, including the CGRP antagonists, including probably any of the headache preventatives and acute medications, except we want to try to stay away from the ones that cause weight gain. So valproate is probably not the greatest choice, for example.
I would just echo that I do treat a lot of people with the combination of acetazolamide and topiramate, and I do find that that is very helpful. But sometimes that isn't enough. And we have used the CGRP monoclonal antibodies, and there have been some small little studies that have shown that maybe patients are better with that. So I think it's worth trying if they've got really bad migraine and it's not responding to medication normally. And the onabotulinum toxin we have tried too, with some success in some people.
So it sounds like topiramate is a favorite because of the weight loss potential, and combination is maybe ideal. But both of these drugs have sometimes tolerability issues, both when used alone or used in combination. So are there alternatives to these two diuretics that you use in clinical practice?
If they can't tolerate acetazolamide, I've used methazolamide, a close cousin to acetazolamide. Sometimes I've had to use furosemide, which I don't think works that well. Chlorothalidone has been reported to be helpful in some. So yes, we do use other diuretics on occasion. As far as an alternative to topiramate, sometimes I've used zonisamide with fewer side effects, but I don't think it works quite as well as topiramate.
But again, for the headache, it's not so much about lowering intracranial pressure at that point, right? Usually these patients, their papilledema has gone away and everything else looks good, but they have ongoing headache. So we would use headache medications. The other thing we found out in the IIH treatment trial was that the prevalence of self-reported migraine prior to developing IIH was a little over 40%, which is more than twice you would expect in the general population, right? For women, it's about 18 to 20% have migraine. So they may be primed to have ongoing headache when all is said and done.
Where is the field opening pressures, right? Because we're all different. We're built differently, some taller, some shorter. And these are averages, estimates. So what are the thoughts on opening pressure?
Don't worship the pressure alone. As Deborah said at the beginning, this is a package deal. You have to have the symptoms. You have to have the signs. You've got to have the imaging. Do you know what I mean? You've got to have all this stuff. So if you hang your hat on the pressure alone, you are going to be mistaken frequently.
Great. So I think that was a great conversation about high pressure headache, IIH, but let's spend a little bit of time talking about low pressure headache syndromes. We're still not maybe diagnosing this as fast as we should, right, when they're spontaneous cases. So how can we improve the diagnostic yield?
Well, first, you really have to have a very high index of suspicion. And that really comes from taking a very detailed history. So the classic person who has what we call spontaneous intracranial hypotension, or SIH, has orthostatic headache. And about maybe 90+% of people who have a SIH have orthostatic headache at some point. But not everybody does. Some people have headaches that are not really either present or severe when they first wake up in the morning before they get out of bed. But as the day goes on, they start to develop a headache that progressively worsens over time. We also like to hear about the headache improving in recumbence. And not just because they lie down and go to sleep and take medicine, but actually just lying down helps the headache. But there are all these other symptoms that patients can have. They frequently will have eighth nerve manifestations, such as dizziness, not really lightheaded, but vertigo, imbalance, muffled hearing, various tinnitus, which is usually not pulsatile tinnitus like IIH, but sometimes it is. They're just myriad symptoms that people can get. And so it takes a logical approach to this. And sometimes maybe even have a list of questions that you want to either ask people or send them home with so they think about it. But in people who show up for evaluation that have what you might think of as a new daily persistent headache or chronic migraine that just kind of never goes away, and whatever you try, it doesn't work, and they're not an obese female of childbearing age, where you think about high pressure, or people that have headaches that follow what would be considered pretty trivial trauma. They may have been in a car accident, they may have had a whiplash injury, they may have fallen and bumped their head, or been in a sports injury, or done a little too many burpees, or even people who have a history of dural puncture, and it can be a remote history. So as neurologists, we're doing lumbar punctures or sending our patients for lumbar punctures. But keep in mind that despite what they used to teach us many, many years ago, a spinal headache doesn't always go away in 2 or 3 weeks. There are some people that have spinal headaches that are persistent, or there are people that have a history of having a lumbar puncture or epidural anesthesia who will down the road develop these new headaches. And it turns out that they're leaking. So it's just something that we really have to have in the top of our mind and be detectives and be really suspicious of so that we can go to the next step.
Yeah, I had a good case of that. I had a patient that had spinal anesthesia for delivery and, recovered and didn't really have headache. It was more like, maybe she had 1 or 2 per month that sounded like migraine attacks, and even there was aura, but she had some kind of subtle dizziness. And she recalled it, being even hard to lift her baby. And one day she was moving a couch and the leak happened in full force. And we saw the leak, we patched her up. But going back, and because she was in her health system, which is helpful, I was able to see those prior visits with my colleague. And these were very subtle, very not like the severe leak headache. So maybe there was some very low grade leak or low pressure that was happening all along.
I've seen this as well, especially after delivery and even diplopia, because they get a little subtle bilateral 6th nerve palsy and it comes on after delivery. And you get the scan and you may not see all the findings. You might not see the nice smooth dural enhancement and all that, but the pituitary may be a little bit more full than you'd like to see, and that tonsillar ectopia may be present as well.
I'll say that we would be doing the health systems a great favor, as well as the patients a great favor, to stop using cutting needles when we do these procedures. There are needles that have a much lower risk of producing a CSF leak. And unfortunately, our spinal trays come with these quinky cutting needles that they just do a lot of damage.
So why don't we talk about a diagnostic testing to better diagnose a CSF leak?
I started to say that you definitely need an MR with gadolinium to look for that dural enhancement, which is so characteristic. It's really smooth. It doesn't have lumps and bumps in it like other types of meningeal enhancement. And then all the characteristic findings on a sagittal view, looking at the pituitary, looking at the distance of the tonsillar descent, and just looking at all the configuration of the whole posterior fossa. And many people recommend getting a heavy weighted T2 imaging of the entire spine. And you really have to work with your neuroradiologist. If you suspect this in your patients, you really have to work with a neuroradiologist, just because they need to know what you're looking for and what you want to be finding. And that's what we do. We have kind of a protocol in our center that when we suspect this, we kind of write that's what we suspect. And then they're much more in tune with looking for all the findings.
The nice thing about the heavily T2 weighted MR, which is also with fat saturation, is that, first of all, it's totally non-invasive. So it often will give you a clue that there is a CSF leak, particularly if it's from a dural tear. It has its limitations, though, so it is not as good as localizing a leak, and it also is not as good for detecting a CSF venous fistula, which is the cause of leaks in about 25% of people who have SIH. So other tests that can be done include a CT myelogram, and this is done differently than when looking for spine disease or low back pain. It's done with the patient prone on the table, not supine on the table. And it can also be done with decubitus views. And then there's another technique that is called digital subtraction myelography, which is a kind of a much bigger deal. You need to go to a specialized center for it. But again, if you get the patient imaged with digital subtraction myelography in the lateral decubitus positions, then the likelihood of picking up one of these fistulas goes way up. But I have to tell you that a lot of times these leaks are very, very hard to find. We do multiple procedures on people, and we have so much trouble finding the source of the leak. And a lot of times we'll just kind of treat them empirically if we're highly suspicious, especially if their brain MRI shows signs of low pressure. So we may just go ahead and do a lumbar blood patch or a multi-level non-targeted blood patch to see if the patient gets better. Once you image the spine, then you can do targeted blood patches, but it helps to have something to target, right? And often it's really hard to find something to target. The other thing that we generally don't do is a lumbar puncture. So even though we call this spontaneous intracranial hypotension, only about maybe a third of people who have SIH have a low pressure, which is 60 millimeters of water or less. So we generally do not stick needles in people's backs to measure their pressure, because it can actually make them worse. And if they go for myelography, then the neuroradiologist or the interventional radiologist can measure their opening pressure at that time if we need more confirmatory data.
What I'm hearing is it's not always easy to find the etiology. There's some more rare cases like the venous fistula and, of course, malformations. There are a number of etiologies. Are there any new management approaches to treating some of these etiologies and diagnosing too, if you want to mention that?
I think the digital subtraction myelography is really kind of the new kid on the block, but it's not done everywhere. And I think this is a team sport. This means you have to work with neuroradiology. You might have to work with neurosurgery if they understand how these leaks occur, because I've sometimes had to have the neurosurgeon go in and close a leak. So I really feel like it's a team sport. And the more you can work together on somebody, the better chance of having some kind of success.
The other thing I would add is that the real challenge is when you have a high clinical suspicion, but the MRI of the brain is normal and it doesn't show any signs of intracranial hypotension. And this happens in probably 15 to 20% of people. So it's not a trivial proportion, right? And then you're in the kind of additionally difficult situation of trying to convince your interventional radiologist or your neuroradiologist to start doing invasive procedures on someone when they have a normal brain MRI. It's not just frustrating for us, it's super frustrating for the patient. And so that's why we would often just go ahead and proceed with doing a non-targeted blood patch at that point. If the patient gets better, then you have a little more evidence behind you that we should look harder.
So we talk about uncommonly diagnosed disorders or lesser known disorders, but these aren't rare disorders. We do see them. Neurologists come across these patients all the time in both academic settings and private practice settings. And from what I'm hearing is that you want to collaborate with people that have experience as much as possible. But let's talk about what an ideal multidisciplinary approach would be. You mentioned working with some neurosurgeons and radiologists. Maybe we'll have Deborah give us high and we'll have Kathleen give us low, or however you guys want to mention it.
Okay, so for intracranial hypertension, the team is, first of all, every team needs a captain. Either a neurologist or a neuro-ophthalmologist should preferentially be the captain of the ship. So for the neurologist in practice, you want to work with either a neuro-ophthalmologist or an ophthalmologist, very important. You probably also need to have good relationships with neuroradiology as well as neurosurgery. And if you're thinking about a stent, then you're going to talk about interventional radiology. You may also have to call your colleagues in the bariatric team, whether the patient's going to have surgery or have just a good bariatric medical weight loss program, perhaps even an endocrinologist if it's somebody that you suspect has polycystic ovarian syndrome. So the team can actually get to be very large at some point. And then headache specialist if you're not a headache specialist, right?
So quite an entourage there.
Yeah.
Great. So let's tackle low pressure SIH.
So have the high index of suspicion in all the patients you see with headaches that aren't getting better. Work with the neuroradiologist to develop a protocol for making sure that you get the right MRI scan of the brain with gadolinium and that they're looking for a SIH situation, and that they know how to do heavy T2 weighted spine imaging with fat saturation to look for a possible dural tear. And then more interventional neuroradiologists that will do a CT myelogram to look for the leak. And if your center can do digital subtraction myelography, that would be wonderful. And finally, which is not easy to find, is neurosurgeons that want to deal with this problem, because it is not an easy problem to deal with. But if you can find one that is willing to work with you, it's wonderful.
I would just really emphasize that neuroradiology is the critical piece of managing and diagnosing SIH. You really need a neuroradiologist who's got a vested interest in it. For those who are in practice in the community or not in an academic medical center, the imaging that your patients get may not be read by a neuroradiologist. It may be read by a general radiologist. And so it is certainly possible that findings are missed because an experienced neuroradiologist is not reading the films.
Great. Any final thoughts?
Well, I'll just say pressure disorders are going to be in our clinics as neurologists all the time, and being prepared to take care of the headache part of this is incredibly important. Getting the right diagnosis is really important, and thinking about the diagnosis is really important. And for our IIH patients, I do think we have to really work on the weight loss first after we've made sure that they're not losing vision. And if you don't have a way to partner to look at the vision, you really have to have somebody helping you with the visual side of this, because we don't want people to lose vision.
Yes, my parting shot is I'm so happy that we got to do this.
Yeah.
And to talk about these problems for all of our colleagues, around the world, basically. It's really been a pleasure and an honor. And for IIH, my diagnostic clinical pearl is follow the diagnostic criteria. We wrote them to keep you safe, keep you away from the attorney, and to make sure that we do the right things for our patients.
Well, that's a wrap up. Thank you both.
Thank you so much for having us.
Yeah, thanks very much.
Well, that about wraps it up for this session on high and low CSF pressures as part of our November headache series.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to